different surface than the smooth, simple squamous epithelium. Plus they have a different charge. And the von Willebrand molecules that have been released by the endothelial cells start to become intertwined and stick to these collagen fibers. And then that forms a bridge between fibrinogen and the platelets. So here we have the collagen fibers and platelets starting to stick to that. That first interaction causes the platelets to release ADP, and ADP makes the platelets sticky, and serotonin and thromboxane A2 are released. Serotonin causes vasoconstriction. Remember, it's a neurotransmitter, also released by neurons, but here it's released by the platelets. Thromboxane A2 does both. It both makes the platelets sticky and it causes vasoconstriction. You have that in your lecture notes. So we start getting platelets sticking to each other, and that stickiness causes them to release more chemicals and more platelets stick. And in amongst all these sticky platelets, we have another molecule we'll talk about in a few minutes called plasminogen. Plasminogen is important because this is how we actually dissolve the clot. So as plasminogen, it is sticky and it gets involved with the platelets, but its active form, plasmin, is what's going to cause the platelet to break, the clot to break down, all right? But it's part of this mass of material accumulating on the vessel wall. So now we've got vasoconstriction narrowing the gap that's caused by the cut. We've got, our little Dutch boy plugging up that gap with his thumb. If you've heard that story, and that would be the platelets sticking to each other. And as I said, many vessel leakage can be stopped just by those two events. The coagulation process helps to strengthen this as it surrounds and embeds these cells and red blood cells in the fibrin threads. Okay. So this itself is not coagulation. This is just the platelet plug. We don't have fibrin threads necessarily involved in this process distinctively as that process. So that brings us to the coagulation phase. So that's the addition. Here's our platelets, and that's the addition of the fibrin components. This is our first exposure to an event known as a cascade. Now, I mentioned clotting cascade and Bio-430 as an example of positive feedback, where the activation of one enzyme or molecule results in the activation of another, and the event snowballs. Rather than trying to stop it, it increases the movement towards a particular catalytic event. Now, you'll notice in your lecture notes, there's two pathways. One is called the intrinsic pathway, and one is called the extrinsic pathway. The clotting factors that are involved in this cascade, we have separate clotting factors for each of the pathways, and then they have a common pathway. Like many of our cascades, complement and so on, these factors were named, numbered, in the order in which they were isolated and discovered, not the order in which they act all the time. And that makes it confusing when you try to learn it. This is not medical school, nor is it biochemistry, so I'm not going to require that you be able to identify and repeat the cascade, but there are key events that I want you to understand and some underlying principles. So, here's a confusing look at the cascade with all these arrows. I'm going to introduce you to a couple of these points, and then I redid the cascade, and I'll show you some of those slides. So over on the left hand at the top, you see the term extrinsic, and on the right hand side, the term intrinsic. Extrinsic means outside. When we were looking at muscles of the tongue, the genioglossus and hyoglossus and styloglossus, those were described as extrinsic muscles. They had an origin outside of the tongue and inserted into the tongue. Intrinsic muscles of the tongue, we didn't have a name. Those are the ones that you would use to make the make your tongue curl up, roll up, or create the clover leaf. I can't do any of those, so I'm not going to demonstrate. But that means within. So when we talk about extrinsic and intrinsic mechanisms, we're talking about the source, the trigger that starts the coagulation process. Does it come from outside the blood vessel or does it come from within the blood itself? So the extrinsic mechanism, if you look at the very top there, it says tissue damage. So there has to be some kind of damage to surrounding fibroblasts and muscle. So this would be like a crushing damage, all right? If you break your leg, it's usually going to cause some damage. You seldom break the bone without any damage to the surrounding area. There's usually some traumatic event that occurred, and so you've got surrounding soft tissue damage. So when those blood vessels are torn, all right, it's going to have some surrounding soft tissue damage. So if I, hit my fist into the wall and break a hole in the wall, and I start bleeding, there's soft tissue damage around that blood vessel that was torn open. So those cells release a molecule known as tissue thromboplastin. It's also known as clotting factor 3, but I don't care about that. I would rather you know the tissue thromboplastin, or TTF, tissue thromboplastin factor. That is going to trigger molecules that are inside the blood, and these are made by the liver, along with calcium. That's the other factor that I want you to know. Calcium ion is required as a cofactor for the activation of these enzymes. In fact, some drugs that chelate calcium, they bind to calcium and don't allow it to be a free ion, are used in blood when you don't want it to coagulate. So you're storing blood in a tube and you don't want it to form a clot. You'll add these chelating factors. They will bind calcium. Without calcium, our clotting factors don't work. Okay, so calcium is necessary for many of these to work. So that's what I want you to know from this screen. I'm not worried about the 9 and the factor 8, although this is a hemophiliac factor right here, clotting factor 8. If we miss there, that is absent. But I'm not going to test you on which of these other factors are intrinsic or extrinsic. For extrinsic pathway, I want you to know that you have to have tissue damage. So tissue damage surrounding the outside of the torn blood vessel releases this comes not from the blood vessel cells, but from the surrounding fibroblasts in that area. And I want you to know that calcium ions are required. Okay? That's the key significance. Factor 10 is going to be the beginning of our common pathway. So either extrinsic or intrinsic, we're going to get to the activation of factor 10. Now let's look at the intrinsic pathway. The intrinsic factors activate chemicals, our clotting factors that are within the blood without the addition of any additional chemical source. So there is no intrinsic factor, all right? There is a change in environment. There is no particular chemical that has to be activated. So our collagen, if we put blood in a glass vial, like the capillary tube or the vacuum tube I showed you in lecture yesterday, and it sits there, it's going to clot. No additional chemicals were added to it. There was no tissue thromboplastin, all right? But because of the negative charges along the inside of the glass wall, chemicals, clotting factors that are already in the blood, Pagman inactive factor 12 there means it's called the glass factor, but it's already in the blood. Okay, that's activated by the collagen by negative charges on the glass wall. So we're not adding any additional chemical like we are with the tissue thromboplastin, which is changing the environment. For some students, this is confusing because you say, okay, blood is put into a glass tube and it starts to clot. Is that the extrinsic pathway or the intrinsic pathway? And their mind automatically goes to, well, the blood is outside the body, so it must be the extrinsic pathway. But it's the intrinsic pathway because no chemicals were added. We changed the environment that the chemicals already present or the molecules already present in the blood now become activated. Okay? So that's the intrinsic. Most of the time, both of them are involved. Because when we cut a blood vessel, we're damaging the outside area and we're adding the tissue thromboplastin and we're exposing collagen fibers. So most of the time, both of these pathways are going to be involved. Notice again, calcium. Okay? And that brings us also to factor 10. If we go back to this illustration here, extrinsic pathway, tissue damage, here's our tissue thromboplastin, calcium ions, we go through a cascade and we get to factor 10. Intrinsic pathway, in contact with collagen or glass, we go through the pathway with calcium and we end up at factor 10. Okay? Now this is the common pathway. This is the most common, this kind of stuff I learned, well not quite elementary school, but high school. So common pathway, this one I do want you to know. Again, we still need calcium. Factor 10 activates an enzyme known as prothrombinase. Prothrombinase activates a molecule produced by the liver known as prothrombin and converts it to thrombin. So the function of prothrombinase is to convert prothrombin to thrombin. Thrombin then is the last molecule that's going to cause our globular fibrinogen to polymerize and form fibrin threads. Okay. So that's what I want you, those molecules I do want you to know, or sequences of events. So prothrombinase activates prothrombin, prothrombin activates thrombin, becomes thrombin, and that activates fibrinogen to fibrin. So that brings us to those long polymerizing threads that in a normal coagulation are going to trap water but also be involved with the platelets and other red blood cells. And so we get this growing mound of cell material increasing the plug at the vessel site. It stabilizes that plug for a longer period of time. Now remember I said that plasminogen is also trapped within, it's attracted to the platelets and trapped within this. So the liver, the plasminogen is activated by a molecule known as TPA, or tissue plasminogen activator, and is converted to plasmin. Okay. Anybody heard of TPA before? I know if you had my class last semester, you did.
I don't remember.
Case study on stroke?
I don't think we did.
I don't think our class did it.
Case study? Okay. So one of the case studies, a guy has a stroke, and he's sent to the emergency room. You've got that magic hour, and the doctor wants to give him TPA. TPA converts plasminogen to plasmin, and plasmin breaks down the fibrin pieces into small little molecules, a little bit bigger than fibrinogen, but breaks them down, and the term dissolves the clot is used, but it really is like little garden shears coming along and clipping the fibrin threads into smaller molecules that no longer form a network of trapping water, and then that is processed by the kidneys and by the liver. So his doctor wants to give him TPA, and the other surgeons are, well, maybe not, because his stroke could have been caused either by a clot or by a ruptured blood vessel in the brain. If it's a ruptured blood vessel, an aneurysm that's bleeding, you don't want to give him something that's going to make him bleed more. All right? So you need to do some scans to decide whether or not it's a clot or it's a ruptured blood vessel that's caused the stroke before you give him something that makes it worse. This is also used for heart attacks. If there's a clot that's blocking coronary vessels or branches of the coronary vessels to help dissolve the clot. Obviously, it's not going to do anything for a ruptured blood vessel. So here are some of the molecules that you might recognized by other names. So fibrinogen and prothrombin all have factor names that we don't typically use. Even calcium ions do. So I'm not going to test you on these. This is just an information table in case you're reading. It's like, for me, acronyms and numbered and lettered structures, that's why I have such a hard time reading genetic papers, because all the genes are given these code names. That once you read the entire name of the gene and what it does, the code names make sense. But just reading about ARCO3 and all that kind of stuff, it's just, my brain has to stop and figure out what that is before I can keep reading. So using factor 4 and factor 3 and factor 2, I'd rather just know what it is, and it makes more sense for me. So this is just kind of to help you. Vitamin K, I do want you to know, vitamin K is involved in the synthesis of prothrombin. Anybody know where vitamin K, how we get vitamin K?
Bacteria in our gut?
It can be added. It's a lipid-soluble vitamin. A, D, E, and K are lipid-soluble. So it is added to milk and stuff like that, but most of what we get is a symbiotic relationship with the E. coli in our colon. They break down the cellulose of plants that we don't have the enzymes for, and they synthesize vitamin K. So this is an injection that's given to newborns. At least when I was working in the nursery, it was an injection. Optimophyton, given into the anterior thighs because they don't have enough muscle or adipose tissue in their shoulders or buttocks, and just kind of raises the level of their vitamin K until normally it rises around day 7 or 8, which by the way is the Jewish tradition for circumcision. And by that time, the infant's vitamin K levels are usually high enough. So those are additional factors. And then we can give anticoagulants, so we don't always want clots to form. We have a family friend that was in his mid-30s. He took a cross-country plane trip and got off the plane, went to the gym that night and started having calf pain, and went to the doctors, and he had a clot from sitting in the plane for so long. Okay, so now, even though it didn't go to his lungs, he's on daily anticoagulants. So there's a variety. Heparin C and Coumadin are probably the most common known anticoagulants. Coumadin is an oral pill that you would take daily. Heparin is done by injection. So if someone is taking antibiotics every day by IV and they don't want to stay in the hospital to do that, they can be sent home with a heparin lock, which is just a needle in the vein with a rubber diaphragm. But the reason it's called a heparin lock is because heparin is given to flush it out before and after the medication treatment to make sure blood doesn't clot inside that needle. So aspirin is known as a blood thinner. It doesn't change the viscosity of blood. All right, it doesn't make the blood any thinner by decreasing the number of cells or adding fluid, but it inhibits the stickiness of platelets. So it inhibits thromboxane A2 synthesis by the platelets. And so it keeps them, thromboxane does both stickiness and vasoconstriction. Okay? So it's not a literal blood thinner. Interestingly enough, I found out, I think it was last year, ibuprofen can also be a blood thinner. Now, kids under 12 are not supposed to take aspirin because of the increase in risk of, I think it's not Guillain-Barré, I think it's Ray's syndrome. But, and pregnant women aren't supposed to take aspirin because of the risk of fetal development, bleeding occurring in the fetus. But I thought ibuprofen was fine, and one of my students last year, her sister had just delivered a baby, and while she was in the hospital, the day before, her daughter had had, the sister's daughter, the niece, had had her tonsils taken out. She was about 7 or 8. And the sister went into the hospital to have a baby, and the daughter started bleeding, hemorrhaging from the site of surgery. And the mom hadn't given her aspirin, but had given her ibuprofen. I was like, that should be okay. But when I looked it up, a side effect of it was a potential, not as serious as aspirin, but this girl had a sensitivity to it and had started to bleed because of the effect of the ibuprofen apparently. Notice the dilution of clotting factors up there? And I told you about that woman who died because she'd been bleeding and got just IV fluids instead of blood. There is a disorder, not so much a dilution of clotting factors as it is using up the clotting factors. And this order is known as, I can remember the term. Clotting dissemination, DIC. Dissemination, anyway, I don't have the actual term here, but it's the term, the abbreviation is DIC. It's a dissemination intravascular clotting component. So what happened, so I had a patient who I was working double and triple shifts the summer before I came out to California for my doctoral program to save money, because I was paying out-of-state tuition the first couple of years. And the last weekend I worked, we had a couple come in they had been trying to get pregnant for about 10 years and had finally gotten pregnant. And the woman had a doctor's appointment, her due date, so she and her husband were at the doctor's office, and the doctor could not find a fetal heartbeat. And so she said, I'll meet you over at the hospital, going over to the hospital, and they still couldn't find a fetal heartbeat, so we admitted her upstairs, and the baby had died in utero. And the parents and the doctor wanted to do a C-section, since the baby was already dead, she wasn't in labor. And the other OBGYN said, no, that's major surgery. The baby's dead, the baby's not in stress, the mother's okay. We really don't have a reason to do this surgery. And so they put her on prostaglandins to soften the cervix, and that caused a reaction. Her temperature almost went up to 105, so she was on a cooling blanket. And finally, about 3 days later, she went into labor. The doctor wasn't there at the time, so another nurse and I delivered the baby. And then the doctor showed up and took her into the OR to remove the afterbirth and the placenta. And she was in there for about 4 hours because little pieces of the placenta had stayed behind, and she just kept bleeding and bleeding and bleeding. They must have given her 10 units of blood. And what had happened was either, I'm not sure, because in looking it up, either the prostaglandins or chemicals from the dead body. The baby did not smell when it was used. I've helped with babies that were born after 40 weeks. And just like they've been in the bathtub too long. Born alive, their skin is sloughing off and everything. This baby was perfect as far as, structure was concerned. There was no cord around the neck. He was a little baby boy. And he looked fine. I couldn't see anything wrong. He didn't look like he had been, dead for 3 days. I stayed with the dad who was holding him in a rocking chair while we waited for the mom to come out. And so there could have been chemicals released from the fetus that could have resulted, I just remembered the disease. Disseminated intravascular clotting disorder. So what happened was she had too many clots forming, the DIC. And that's why her blood wouldn't stop bleeding. So tiny, tiny, tiny little clots out in the periphery of her body, all over her body, had formed and used up a significant amount of her clotting factors. So when she needed the uterus to constrict, the vasoconstriction that occurs after birth is separated, and clots to form at that time, there were insufficient clotting factors left in her blood. So it was kind of a oxymoron kind of thing where she couldn't clot her blood because too many clots had formed. So it wasn't that she didn't make the factors, they had just already been used up.
Does that make you susceptible to stroke, having all those little clots forming?
If it continues, yeah. I mean, in hers, she had a specific event, but certainly if you have clots forming in other areas.
Did she die?
She didn't die. I went to visit them before I left, and they had said, you know, enough with, we're going to adopt. They just had no mental strength to go through that again. And I wasn't around, so I don't know if they wanted an autopsy. I don't know if they ever found out what had happened. I mean, it could have been erythroblastosis fetalis disorder. I mean, that was her. She could have, you know, she could have had pregnancies that had not developed previously. All right, so a couple of disorders. But we're not going to get to the disorders at all. We've got 15 minutes. Okay. So thrombus and embolism. How are they related?
An embolism is a blood clot that goes where it's not supposed to.
Okay, so thrombus is a stationary blood clot. All right. An embolus is what we call that when it moves. So a couple of summers ago, one of my daughter's friend's mom was hospitalized because she had a thrombus extending from just above her knee all the way up to her external iliac vein, blocking her femoral and external, just about to where the internal iliac formed. And of course, she had to be hospitalized and given fibrinolytic drugs. So I was like, well, I hope they put a stent above that so any little clot breaking off would head on up to the heart, because a clot in place is not a problem unless it's an arterial blockage or a major organ, but it's when it moves and lodges in the lungs or in the heart or in the brain that it can cause serious problems. In fact, the first death in the Iraq War was a journalist who suffered a pulmonary embolism. And it wasn't a soldier. And so this is why if someone has, anybody know what signs of a deep vein thrombosis? DVTs, have you ever heard of DVTs? Some of you working in the hospital may have. Deep vein thrombosis, it usually occurs in the back of the leg, in the calf, so in veins. Remember, your veins are your volume reservoirs, and if you're standing a lot, and as your blood pulls, gravity can pull the red blood cells and the platelets down, and they don't have adequate circulation. That's why people wear compression socks if they travel on planes, because of the inactivity. And so if someone, a typical sign of DVTs are the area of the calf feels very hot, and if you ask them to dorsiflex, point their toes upward, it's very painful to do that. Those are the two classic signs. You never want to give those individuals rubs. You want to start rubbing their legs, you know, toward the heart, because you're just going to encourage the movement of the thrombus to break up the thrombus and move towards the heart tissue. Thrombocytopenia. Penia is a decrease in the number of. So individuals with thrombocytopenia have insufficient numbers of platelets, and therefore they have these bleeding episodes. So these are just lots of little bleeds under the skin. And then there's hemophilias. So hemophilias also are lots of bleeds, but it's due not to lack of platelets to trigger the plug, but due to lack of clotting factors. The most common, well-known one is clotting factor 8. That's the hemophilia of the Russian Tsar family.
So thrombocytopenia is lack of platelets?
Decrease. The normal, remember I told you red blood cells were 4.5 to 6 million? I didn't tell you white blood cells. Anybody know the range of white blood cells? 5,000 to 10,000 per cubic millimeter. Huge difference when you were looking at the slides yesterday. Platelets are around 450,000, 450 to 550,000. So they're tiny, and they're a lot more numerous. So less than that 400,000 number is going to be thrombocytopenia. Per cubic millimeter, mm cubed. All right, well, let's get started on the immune organs. The what?
Red blood cells,